Okay. All right. Well, welcome everyone. We hope that Charmaine can get in and Sue's going to come a bit later. Uh, so, um, so yeah, I think the majority of us are here, and thank you everyone for coming. And we have a very interesting topic, and very knowledgeable people that are going to give us a presentation and and answer our questions. So right now I will turn it over to Crystal, and there you go, Crystal.
Hi everyone, it's good to see you all again. So yeah, today we are joined by Cara and her colleague Sephora, who are from the Toronto Academic Pain Medicine Institute located in Toronto. It's a comprehensive interdisciplinary academic pain program serving as a hub for the chronic pain care in Toronto. So they're going to be specifically talking about chronic pain as well as how to manage it. And yeah, I'll just turn it over to them and they can get started.
Thank you, Crystal. So yeah, I'm just going to share my screen here. Please let me know if you can't see it. And Alan showed me this really cool button, so I'm going to try that button too. All right, we good? You guys can see?
Yeah.
Okay, perfect. So yeah, thank you for the introduction, Crystal. So I'm really excited to have been invited to spend the afternoon with you today. So like Crystal said, I'm Kara Stanley, and I'm one of the nurses with TAPMI, so the Toronto Academic Pain Medicine Institute, and we're actually based out of Women's College Hospital. So just slightly off the path of where all the big hospitals are on the main stretch of university in the city. And I'm really excited to have Sephora here with me today. So Sephora is our clinical extern who's here working with us for the summer. So she's just about to enter into her final year of nursing school. So she's been working with our team, taking on different projects and learning lots. So she's really excited to share some of what she's been learning with everybody today. So I had the privilege of meeting with Crystal and Susan and Alan a little while ago to sort of understand what you wanted us to talk about today, because I'm in the pain world every single day. This is what I do Monday to Friday, 8 to 4. So there's lots of different things that I could talk about. But we sort of thought it would be a good idea to talk about what is chronic pain and sort of why do we experience pains in our body? Because no matter sort of our age, our gender, our sort of underlying health conditions, sort of the science behind chronic pain is the same. So I'm comfortable with people. If you have any questions, feel free to interrupt me at any time. I've also put together a few resources about chronic pain management, or if you wanted to learn a little bit more of what I'm talking about today, I've put together in a document that Crystal can share with everybody. But we're going to talk a little bit about some of the resources too as we go through our chat. So in terms of what I'm going to speak about today, we're going to talk about like what is pain? Why does pain exist? What are the differences between the types of pain? So acute pain versus chronic pain. What's our nervous system? How is our nervous system involved in our body, sort of pain response and our perception of pain? We're going to talk about the concept of neuroplasticity. Which will make a lot more sense once we start talking about the nervous system. And then, like I said, we're going to talk a little bit about some resources as well. But we like to start every group gathering with a land acknowledgement. So I just want to take a few moments to acknowledge that the land we're meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis people. I also want to acknowledge that Toronto, where I'm joining from, is covered by Treaty 13 with the Mississaugas of the Credit. All right, so what is pain? So pain is whatever the person says it is, and it exists whenever the experiencing person says it does. But pain is also a sensory and emotional experience, and it's one of the many protective mechanisms that our bodies have that compels us to do something to protect. So the definitions on the slide are sort of those medical jargony definitions of what pain is. But when we say that pain is sensory, we're referring to something that we feel. And that's usually what comes to mind when you hear the word pain or you feel pain. You're like, well, yeah, I feel it. That makes sense. But pain is also an emotional experience. And in a few minutes, we're going to speak about why we have that emotional response to pain in our bodies, and why having that emotional response to pain over time can be not a great thing, which is sometimes what happens in people's bodies and people's experiences when we have chronic pain. But at the end of the day, pain is a really complex phenomenon. And there's different reasons why we can experience pain. So sometimes it's a result of tissue damage, sometimes it's because of medical conditions, and sometimes we don't know why. Some people just experience pain and we don't really know exactly why. We can't sort of say, oh, it's because you have this illness or this sort of thing going on in your body, which can make it a really frustrating experience for a lot of people. But it's really important to know that pain is common. And in Canada specifically, 1 in 5 people have persistent pain. So throughout the presentation, I'll use persistent and chronic pain sort of interchangeably, but I mean the same thing. So persistent pain and chronic pain are the same. And in some countries, that estimate is about 1 in 4. And people with different diagnoses and certain populations of people, that number can be a little bit higher than that, which can kind of sound really depressing and sort of sad to think about. But it actually tells us that a lot of people are coping and functioning well despite persistent pain. And so there is hope that we can learn and manage pain for people who are struggling. And I sort of think about it like, okay, as somebody who commutes to work every day in a public transit system that's in Canada, where this 1 in 5 sort of statistic came from, that means 1 in every 5 people that I'm looking at in front of me on the subway, one of these people is experiencing chronic pain. And I can't tell by looking at you all of the time that you're experiencing chronic pain. So pain is normal. So pain is part of that normal sort of experiences within our body for what our brain perceives as a threat. So pain doesn't always mean that there's damage or harm going on, but our brain is perceiving that there's a threat. So there's many things that can hurt a lot, but don't harm us at all. So the example I like to give is like a brain freeze. It really hurts. It's really uncomfortable, but I'm not getting brain damage because of that pain that I'm feeling in that moment. Sort of on the flip side, we can have situations where we're actually experiencing a lot of damage in our body, but I don't feel any pain. So an example that I like to use to sort of make this point is, I don't know if people are familiar with the surfer Bethany Hamilton, but she was a young surfer in Hawaii who was surfing, and her arm got bitten off by a shark. So she didn't feel pain in that moment, because at that moment, her brain was like, yeah, we're missing our arm, but right now there's a shark and we need to swim to shore. So her brain's like, that's where we're going to focus our energy. Ignore this pain. But I'm going to increase your heart rate. I'm going to give you that energy. I'm going to sort of focus your energy on getting to shore. So she was able to get to shore. And it was once she was safe and her brain's like, okay, we can exhale now. We're safe. There's no shark. Then she started experiencing pain and realized like, oh my God, my arm is gone. So we're going to talk a little bit about why that happens within our nervous system in a few minutes. But again, our brain decides what level of pain we should experience, and our brain makes that decision, sort of that order of priorities. So am I going to feel pain in that moment? Because our brain's like, I want you to focus on this pain so that you don't do any more harm, or we need to swim to shore because there's a shark. Does that make sense?
Yep.
Yeah, the shark example is like an extreme. A more practical example is like, okay, I'm walking in the woods and I hear what I think might be a bear behind me. So I trip on a stick maybe, I have a scratch, but I'm like, oh, I think there might be a bear. So I'm going to get to safety. And then maybe once I'm relaxed and I know that there's no bear, then I might feel that pain in my knee. So there's two types of pain that we experience in our body, referred to as acute pain and persistent or chronic pain. So acute pain is what most people are familiar with. So it's that pain that's temporary, and it's usually caused by a specific injury or condition. So there's what we call an incident event. So something happened. So I fall and I break my ankle, or I go and I have surgery. We expect there to be pain when we have a broken bone or a surgery. And so that pain that we feel in the moment while we're recovering or while our bone is healing, that's what we refer to as acute pain. Persistent pain is pain that lasts longer than that expected period of healing. So we say about 3 to 6 months. So maybe I had a broken bone. My x-ray showed that my bone is healed. I've done all the physio, I've done all the things I'm supposed to do, but I'm still feeling pain in that ankle. So we would refer to pain at that point as persistent or chronic pain. So no matter where in our body we feel pain, all of our pain experiences are processed by our nervous system. And our nervous system has three parts. So we have our brain, our spinal cord, and our body, or our peripheral nerves. So we can think of the peripheral nerves, which are shown here. Actually, this is what here in the yellow. So I like to think of those sort of as like the side streets in a city. So information is going both ways. So cars are going in both directions. So the information's either going from our peripheral nerves up our nervous system to our brain, or from our brain back down to that body part or that specific nerve. We can think of those spinal cords like the 401 or a major highway. So all those side streets sort of feed into that main highway. And again, traffic goes in both directions. So we're going back up to our brain, back down our spinal cord, and vice versa. And then we have our brain. So the brain can sort of be like that downtown core. So that's where all those big decisions are made, all the government buildings where all the big people are. And decisions that are made in our brain affect the rest of the city. And there's actually activity going in all directions in all parts of our brain. And all parts of our nervous system communicate to one another. So no matter where in our body we feel that pain, it's all processed by our brain. And our brain is responsible for making that decision about whether or not we experience pain in that moment, or whether we need to get to safety, or sort of be on guard for danger, for example. So to start, we're going to talk about sort of what happens in our peripheral nerves, so our tissues in our nerves. So our body contains more than 400 individual nerves, and all these nerves are interconnected sort of like a highway. And these nerves connect to our spinal cord. So like we said before, those messages can be sent to our brain, where our brain sort of processes that information. But at the end of all of our nerves, we have these tiny sensors that are called nociceptors. And these nociceptors are receptors for stimuli, so for those painful stimuli. So these little receptors here that are shown in the different colors. And nociception is the process where those receptors on the ends of our nerves are picking up sensations and sending those messages to our brain. And our brain loves context. So depending on sort of our biological or physiological and the social factors around us, our brain is always filtering and analyzing sort of the context for that information. And sometimes we don't know it's happening because sometimes we don't feel any different in our body. So I like to give the example of like the elastics being super tight on your socks. So sometimes that's not painful. Sometimes I'm more aware of that sort of scratchiness of the elastic or the tightness. But that's a good example of sort of those receptors are picking up sort of that sensation and sending it to my brain. So my brain's like, it's not painful, but I'm going to make you feel itchy now. And that itchiness goes back to my brain, and then I respond by itching that area. And there's different sensations that are picked up on these receptors. So ones that are sort of people may be more familiar with, like temperature, so hot or cold. So I put my hand on a hot stove, my hands, the receptors and the nerves in my hands are picking up that increase in temperature. It goes up to my brain. My brain says, Kara, get your hand off the stove. That's not a good idea. And I lift my hand up. And it happens so fast. Like if we think about if we get too close to like the pot and we accidentally graze our knuckle, like it's instant, right? You're like, ah. And like that's how fast these messages are going up and down our brain. We have mechanical stimuli. So if I hit my head or my finger with a hammer or I step on a sharp nail, so it's usually sort of pinch or pressure or sharp. Again, that message goes up to my brain. I'm probably not going to continue to weight bear if I'm stepping on a nail. I feel that sensation. My brain's like, oh, don't step there, it hurts. And then I sort of pull back or take my foot off that sharp object. But we also have chemical stimuli. So these can be things like, okay, I brush up against poison ivy or inflammation in my body. So maybe I have a burn or I'm having an allergic reaction to, I don't know, like a Band-Aid or something that I've rubbed up against. Those are examples of chemical stimuli. Chemical stimuli can also be things like lactic acid. So if we've ever maybe not had enough water to drink, maybe done a lot of exercise, you sort of get those muscle cramps. And that is a result of that lactic acid building up in our muscles. But that's an example of another sort of chemical stimuli that happens in our body. And again, sometimes that doesn't result in pain. Sometimes we feel itchiness or a different level of discomfort that's not necessarily pain. So nociception, or sort of that sensation being sent to our brain, doesn't always happen when there's stimuli. We also have sensory nerves on the end of all of our nerves that's relaying information to our brain to tell our brain where in our body that sensation is coming from. So is it coming from my left foot versus my right foot, or my pointer finger versus my thumb? But once those sensors detect a threat, it's sending that warning signal up our nerve up towards our spinal cord. So from those sort of side streets in the city up to the highway, so that the information can continue up through our nervous system. So once that message, or what we call the danger message or that pain message, reaches the end of our nerves, it goes to the spinal cord. So I'm just going to share it here. So what I'm speaking about is this little space here that kind of looks like outer space. So this is the end of our nerve here on the left. Where's my left? Is it flipped for you? My left. And then this is where the spinal cord nerves are. So the space between where our nerves end and our spinal cord begins is called a synapse. So it's that tiny, tiny gap between nerves. And this is like what it looks like under a microscope. It's like teeny, teeny, tiny. And in the synapse, this signal changes from a electrical signal, to a chemical signal. So our nerves release chemical messengers that are called neurotransmitters. And these neurotransmitters are responsible for telling the spinal cord nerves what to do. And all these chemicals fit into these receptors in a spinal cord nerve, kind of like, I like to use the example, I think because I have young kids, of those little like shape sorter toys. So the square fits in the square receptor, the circle fits in the circle, etc. So all the neurotransmitters have their own sort of receptors that they cling onto. And this is a really, really important place because this is where those danger or those pain signals can continue up to the brain, or they sort of stop and they don't make it all the way up our nervous system. So as long as there's enough chemical messengers here, these little dots, those neurotransmitters, then that message will continue up the spinal cord. If there's not enough, then that message sort of stops and it doesn't go back up to the brain. Oh, I'm sorry. And this is really an interesting place when we think of different things that we use to treat pain. So when we talk about some of the categories of medications that we use to treat pain, they work on, a lot of them work on these neurotransmitters. So some of the, depending on sort of the types of pain that you're experiencing, sometimes we use medications that work on these neurotransmitters. So sometimes we prescribe antidepressants. So antidepressants work on pain because they decrease the amount of those they sort of overpower those danger messages by increasing those good messages. So if we have good more increase in what we call calming signals to the brain, it's going to overpower that danger signal. So not as many danger signals are going up to the brain, or those pain signals. Medications like opioids specifically, opioids don't work on these neurotransmitters. They actually work on the receptors. So opioids work by blocking the receptors. So when we use the example of they're sort of fitting like a lock and key, or those little shapes fitting in certain shaped holes, they're like, no, we're going to block the hole. So now you have all these pain signals. They have nowhere to go. They can't sort of click onto their lock. Then that message isn't going to go to continue. But what happens with opioids is that our brain is smart. Our brain's adapting. It's like, hey, I'm sending you all these pain signals. You're not responding. You're ignoring me. I'm actually going to make more receptors. So with opioids specifically, some people find like they're really helpful for their pain, but the longer you're on them, some people find that they need like increasing doses. And that's because our body's responding by making more receptors, because it's like, hey, dummy, I'm trying to protect you. I've got these danger signals. Stop ignoring me. And that's when it can sort of get dangerous, because when we're on high doses of opioids for a long period of time, it can start to affect different centers in our brain, specifically the respiratory centers. So we don't want to sort of have it impact our breathing, which is why some of the clinicians that I work with help people sort of find that safe balance with medication. So maybe we're going to decrease opioids or prescribe opioids in a different way, so that we're making sure we're not affecting those other sensors in our brain, and making sure that we're keeping people safe. But there's other sort of not medication sort of strategies that we use for pain that work on our synapse as well. So things like cognitive behavioral therapy, or even just relaxation strategies, they work by increasing those calming signals too. So when we're able to relax, we're able to sort of decrease our stress response in our body. We're increasing those calming signals, which again is going to sort of overpower those danger messages that are going up and down our nervous system. Exercise works that way too. So I think a lot of people are familiar with like, exercise makes us feel good. Maybe not when we're first starting, but like the longer we find an exercise that we enjoy, like a dance class, or maybe, I don't know, Zumba is a good example. Or maybe just an activity that I really enjoy. My body's releasing endorphins, and endorphins are sort of those feel-good chemicals in our body. And again, they're going to overpower that danger message. So it doesn't necessarily mean that it's going to that pain relief that we're experiencing maybe while we're exercising or shortly after is going to last. But it is still a good way to help relieve pain for even just a short period of time. So again, when we have enough of those neurotransmitters, enough of those danger signals in this synapse, then that message travels up to the brain. Are there any questions about this? I find it interesting. I hope you find it interesting. Okay. So when that message reaches our brain, it's sent to all these different areas. So these are like, there's way more areas in your brain than these 8, but these are the major areas in our brain that are involved with pain. Actually, I probably wouldn't have a job if there was one pain center in the brain, because somebody who works in a lab somewhere would probably have figured out a procedure or a surgery or a medication that would target that area of the brain, and like pain would be cured. Unfortunately, it's a little bit more complex than that. So we're not quite there. But all of these 8 areas in our brain, like I said, are involved with our pain response. So we have our sensory cortex, and that's sort of a representation of all of the parts of our body. So that's where our brain is processing, like, okay, where is that message coming from? So Kara stepped on a nail, so it's her right foot. So that's where the pain is. So maybe we're going to tell you to like stop stepping on the nail. So we have our premotor cortex. And again, that's also a representation of the parts of our body, but more so around movement and executing movement. So giving my nail example. So my sensory cortex said, okay, Kara's right foot is stepping on the nail. My premotor cortex is going to be like, okay, Kara, take your foot off of the nail. So we have our cingulate cortex that's responsible for sort of concentration and focus. So when we're in pain, all of our attention is focused on that danger or that warning signal, which is why some people find that they're really distracted by pain, because our brain's like, hey, do something about this. Like there's pain going on. And that's because of that cingulate cortex. So we have our prefrontal cortex, so it's just right at the front of our brain, and that's associated with problem solving. So this part of our brain is sort of getting the cogs turning about like, okay, what are we going to do to get rid of this pain? So, okay, I need to maybe take my foot off the nail, and then I'm going to look at my injury to be like, am I bleeding? Is there something that I need to sort of do to help relieve this pain or get to safety? We have our hypothalamus and our thalamus. So that's responsible for that stress response. So going back to my Bethany Hamilton example, so it was her hypothalamus that was like, fight or flight. I'm sending all of the oxygen to your muscles so that you have the energy to get to safety. Ignore the pain, swim to shore. So we have our amygdala, and that's that emotional center of our brain. And pain as that protective mechanism is supposed to be unpleasant. And it's useful to have sort of that worry and that fear in the short term because it forces us to react. However, with chronic pain, when those areas of our brain are constantly sort of on alert, that's when some people experience sort of anxiety, sometimes depression, worry, sort of those negative thoughts that sometimes go along with chronic pain. And that's why, because we have this area right here in our brain. We have our hippocampus, and that's responsible for memory. So tying back into that context, that's part of the combination of sort of that cingulate cortex and the prefrontal cortex. So it's like, hey, I've experienced this pain before. What did I do about it? Sometimes when people have a traumatic response, maybe driving by where they may have had an accident or a negative experience, some people feel an increase in their pain, even though they're just driving by where they might have had a car accident, for example. And that's because we have that memory response when it comes to pain. And then we have our brainstem. So the brainstem, we kind of think of like as the off-ramp between our spinal cord and our brain. So that's where the messages get passed from the spinal cord up to our brain. And all of these areas in our brain are connected through what we refer to as sort of like a complex network of cells, and that we call the neuromatrix. So the neuromatrix is sort of, it's a pathway that all those signals travel along. And so the purpose of the neuromatrix is to organize all that information that's coming into our brain so that our bodies respond as a unified whole. So that's what happens with pain. So it's not like, okay, first I'm going to take my foot off the nail, and then I'm going to pause, and then I'm going to be like, oh crap, I'm bleeding. What am I going to do about it? It sort of all happens simultaneously. It's because we have these neuromatrix as that pathway that's connecting all of these areas in our brain. And it's super, super quick that this happens. So when our neuromatrix gets this information, our brain is deciding what it's going to do next. So am I going to feel pain in that moment? Like, I want you to feel pain. I want you to stop what you're doing, maybe brace the area so we're not, so we're preventing further damage, for example. Is there going to be movement? Do I need to swim to shore, get away from the bear that's chasing me in the woods? Do I need to use movement, brace that area? Do I need to turn on that stress response to increase your respiratory rate, get oxygen to those muscles, distract your brain from your arm that's been bitten off by the shark? And sometimes it's a combination of all of these in order to protect us from what our brain thinks is a threat or danger. So I like analogies. So I like to think of the neuromatrix sort of like an orchestra playing a song. So just like all the people playing all these different instruments are working together at the same time to create this beautiful song, it's just like what's happening with our neuromatrix. So over time, our brains can keep playing that same song sort of automatically. Like it happens automatic. We don't have to think about it. It plays by memory. And if you've ever had a song stuck in your head, it's sort of hard to think about or play another song. It's sort of always on in the background. However, if we were to change one of the instruments that are playing, maybe we're playing it a little bit faster or at a different tune, the overall song that the orchestra is playing sounds slightly different. So the same happens with pain. So this is where some of the strategies that we use to help chronic pain sort of ties in. So if thoughts or movement or sensation or any part of that brain pain orchestra changes, that whole pain song is different. So our whole experience with pain can be a little bit different. Are there any questions? Does this all make sense?
Mhm.
Okay.
Good.
Okay. So why does pain persist? Like, why do I have pain? I recovered from my surgery, my fracture is healed. Like, why do I still have pain? And some people sort of, okay, my pain started in my leg and now it's sort of all over. It's widespread. Or I can't really exactly tell where that pain is coming from. So why? So sometimes pain can be associated with a chronic condition, or some people may have had the experience of where like we can't really put our finger on why you're experiencing this pain. But there are some chronic conditions that can cause pain. So things like arthritis. So when we have arthritis, we have inflammation, and with inflammation, it's changing those chemicals in our body. So it's increasing our sensitivity. So it's affecting those neurotransmitters. So sometimes it's speeding up the speed of that pain response through our bodies, or sometimes it's increasing the number of those danger signals. We can have neuropathic disorders. So those are disorders that affect the nerves in our body. So again, if we're having something that's affecting the nerves in our body, that's going to impact the amount of signals that are being sent up our spinal cord for our brain to respond. And then things like heart disease and diabetes. So in itself, they don't cause pain. However, there's a lot of complications associated with heart disease and diabetes. So things like neuropathy or heart disease specifically, sometimes we have constriction of our blood flow, and those are things that can cause inflammation and sort of changes in our nervous system over time. And then we can have conditions that we don't always know exactly what the cause is. So things like regional pain syndromes. So that's a result, and fibromyalgia. So these are things that happen because our whole nervous system is overly sensitive, and we have an increase in those pathways in our brain that are sending those pain signals. So again, with those widespread pain conditions, our brain is sort of protecting you from dangers that don't exist. And again, we're always, all those 8 areas in our brain are always impacted. So this is where a lot of people experience those sort of negative emotions that come with pain. Starts to affect your movement and your stress levels, because all of those parts of your brain are sort of always on guard for danger. So going back a few slides when we talked about the difference between acute pain and chronic pain, with acute pain, our brain is sort of creating that coordinated response to protect ourselves from danger or harm. So the signals go from our tissues to our spinal cord, our brain analyzes it, and then we we respond, and usually with an action. So for example, I put my hand on a hot stove. The message goes from my hand up my arm to my spinal cord to my brain. My brain says, dummy, get your hand off the stove. You're probably going to hurt yourself. And the longer my hand is on that stove, the higher the intensity of that stimulus. So my brain is going to send that alarm to be like, Kara, take your hand off the stove before I end up in a situation where I have tissue damage. So that's that like instant, like, hot, and you take your hand off. Maybe I have a tiny, tiny little red mark, but I likely not going to have sort of any long-term damage. But the longer I hold my hand on that hot stove, the the higher that the stimulus intensity. If I ignore it and continue to hold my hand on the stove, then I'm going to end up in this area where I have damage. So that makes sense, right? Just before injury, I have a warning, take my hand off the stove. Pain serves its purpose. I'm safe, no injury. With chronic pain, usually our body tissues have healed sort of as well as they can. But those nerve connections that are involved in creating pain become more responsive, more sensitive, and those mechanisms that can normally sort of help with those pain signals are impaired. So we refer to this as sort of central nervous system sensitization. So our nervous system is overly sensitized. So that alarm is sounding way before it should. So going back to that previous example where I put my hand on the stove, the longer I hold it, the higher that intensity gets. That alarm goes off just before there's damage. With chronic pain, this is where the damage occurs. So the area, like that threshold, is bigger. However, that alarm is going off even like I'm not even close to where there's going to be damage. So maybe I'm like using my example of the hot stove. Maybe I turn on the stove and my hand is like, you hurt yourself. But I'm like, no, I haven't even walked to the stove yet, or haven't even gotten near where it's hot. So that alarm is sounding and there's no danger. There's nothing going on. And some people sort of learn about pain and they're like, okay, there's no damage going on in my body. I'm just going to ignore it. But the longer we sort of ignore that alarm, some people find that they end up in a flare. And some people, it's a flare in their pain where like, okay, I'm exercising, I feel a little bit of pain, I'm going to ignore it, I'm going to push through and finish my workout. But then some people find that they suffer for it. So sometimes they have a flare in their fatigue. It's like, I'm going to ignore the pain, I'm having a really good day, I'm going to get everything that needs to get done. And then I'm like on the couch for 3 days because I'm so tired or my pain is so bad after that because I sort of ignored that alarm. But there's things that we can do to help sort of push that alarm a little bit farther to where it should be in terms of alarming just before we reach damage. And that's where a lot of the pain strategies come in. So we're sort of helping to change those pathways in our brain to be like, okay, I know there's no harm going on. I'm going to sort of push those boundaries so that I hopefully don't end up in a flare. And sometimes it takes a lot of time in order to make these changes in our nervous system, but the more we practice, and sometimes it's trial and error too, the more we practice these strategies, hopefully we'll be able to sort of push this alarm back up to where it's supposed to be. So that overprotective pain system reduces our risk of re-injury. And that's because that pain system is alerting us to danger sooner than a normal protective system would. So it's giving us this big buffer. So it's like, I'm going to make you feel pain here before there's damage. Does that make sense? I always sometimes explain it to like, okay, if I have my finger, I'm going to pull my finger back. I'm going to feel pain just here because my finger's like, okay, if you keep going, you're probably going to hurt yourself. Maybe you're going to break your finger. So you should probably stop doing that. But with chronic pain, maybe it's I just lift my finger like this and then I feel pain. So there's probably no damage going on. I'm not overextending my finger, but even just moving my hand is causing that pain. So again, normal response like, okay, Kara, you might want to stop. But now with chronic pain, even just opening my hand or moving my fingers, I'm experiencing pain, but there's no damage happening or no danger. So I'm going to hand it off to Sephora, who's going to talk a little bit about neuroplasticity and sort of why are those changes happening in our nervous system.
All right. Can everybody hear me okay? Perfect. So the good news is that while our protective systems can become overly sensitive, neuroplasticity, which is our brain's ability to change and adapt, suggests that this sensitivity can be reversed and can be done at any point in life. So whether you're younger and older, it doesn't matter. You can have that change happen. So this involves interventions that retrain the pain system, helping your body to respond to pain appropriately again. So actually telling you when you are having that danger instead of being overly sensitive and telling you this response when you're not actually experiencing the danger. The brain is always trying to work to protect you from future dangers by altering pathways that regulate emotions, memory, movement, stress, and more. Over time, these pathways become stronger, allowing pain messages to be sent more quickly and easily, like the chronic pain signals you get. However, we all have the capacity to create new pathways. Just as we can learn new languages later in life, we can also learn to interpret our pain signals. So our brain connections are like pathways through a forest, just like you see in the pictures above here. We have the more crowded path, and then we have the more clear path. When we repeatedly use the same parts of our brain and send messages the same way, it's like creating a faster, more worn down path, just like the one on the left. Neuroplasticity occurs throughout our entire lives, not just during childhood or adolescence. Every time you learn, experience, or remember something, you are changing the connections in your brain and creating the new pathways, which makes it easier to send signals throughout your brain and body. The challenge is that our brains cannot distinguish whether what is good, bad, helpful, or unhelpful. This can lead to both positive and negative changes in our brain, just as we see in chronic pain, which is why the brain creates these pathways that lead over to oversensitivity because it doesn't know that it's bad. It just knows that it's trying to protect you. So here we have the overview of pain management. So self-management and medical treatment are both important parts of your pain management plan. Ongoing self-management of your pain and healthcare allows you to be the one in charge of your health and is important regardless of your diagnosis or health condition. We know from other people with persistent pain that these are the areas that have the greatest effects on the quality of life. From a medical treatment perspective, we consider things like medications and our surgical interventions to be effective if they reduce your pain by 30%. If we think of this on a scale, so from 0 to 10, where you rate your pain as 10 out of 10 on the intensity scale, if we provide you a medication and it reduces your pain to a 7 out of 10, the healthcare provider would consider this effective. We also need to balance the effectiveness of your medications with side effects. Sometimes a medication works for pain, but also makes you so fatigued that you can't engage in your daily activities. Some people don't choose medications for these reasons because it can impair their ability to live their life. So if you have a certain goal of you want to continue working and be active, maybe this wouldn't be the choice for you because it's outweighing the effect of pain relief. So we have self-management approach is based on principles of neuroplasticity and learning. The very first step in managing persistent pain is understanding what is happening in your body. There's good evidence that suggests that understanding what is going on in your body will decrease your pain signals. So you can think today as the first step in managing your pain because you are learning about pain today. There are many different parts to self-management. These ones focus on long-term neuroplastic changes to the pain system. So first, we talked about learning about pain. Secondly, we have calming stress. This helps to decrease the sensitivities of our pain system by lowering our nervous system's arousal to be in a more balanced and relaxed state. This is key for making neuroplastic changes as our brain is much more malleable when we're relaxed. So for number 3, we have adapt activity. So we want to continue doing what's important by finding new ways to do what matters. So for instance, if you enjoy cooking, but you can't stand for long periods of time, you could think about maybe sitting instead of standing so that you continue to do what you like to do. Physical activity. So for many, physical movement can be daunting as it may be a cause for pain. However, engaging in physical activity helps to decondition the body, so get it retrained up and get it stronger. It also retrains the brain's response to movement. This can be achieved through graded and enjoyable physical activity. So this means if you're not able to do something right away because it causes pain, such as taking like a 10-minute walk, you could start with something a little bit smaller, maybe like a 5-minute walk, and then slowly increase that over time. Next, we have cope with thoughts and emotions. So mood and pain interact and affect each other. So for instance, if you're having a lot of fear or anxiousness or stress, you're probably going to be feeling that pain more. Whereas if you're happy and more relaxed, you're probably going to feel less pain. For 6, we have sleep strategies. So finding a way you can get a more restful sleep, because when you improved your sleep, you're going to have a better mood. Your body's going to be more rested and relaxed, and so you will be able to manage your pain more. Next, we have setting small goals. So it's good to start building your habits and your confidence and create a more paced schedule. It's also really good for if you're having flare-ups to have a plan set in place so that when you are having a flare-up, you know different strategies that can help you to decrease so that you're not having as much pain during those times. Our recommended approach is based on principles of neuroplasticity and learning. It's about taking charge of your healthcare by taking an active approach to managing your pain. These skills and approaches are based in evidence that shows they can help create a sense of safety for your body to help lower the pain signals.
I just want to add too, so tying in all of these sort of strategies and where does that make sense, and like what Kara just talked about, going a few slides back when we talked about moving that alarm closer so that is alarming more when we're closer to that tissue damage sort of little gray box. So that's where all these strategies fits in. So how can we sort of help reinforce to our nervous system or change those pathways that immediately cause that alarm to go off when we're nowhere near anywhere there's actual damage coming. So all these strategies, when we practice them over time, get a little bit better, make them more of like second nature habits. It's all working on moving that alarm a little bit farther up that sort of graded chart that we shared.
So on this slide, we have some resources that we talked about previously in the beginning of the presentation. So we have the Power Over Pain portal, which is actually a rapid access free science-backed online resource. And it has a lot of different articles, videos, podcasts, self-directed courses, and peer support. We just have the website there listed underneath. We also have the Pain U online, which is actually on the TAPMI website. It teaches people about chronic pain, how it affects the body, different strategies for self-management, and different treatments available. Next, we have the Progress Over Pain portal. It's a 6-week online program that focuses on self-management, and there are different units that you can go through. It's online, and all the links are available there.
Yeah, and all of these resources are on that list that I gave to Crystal too. So the Progress Over Pain group is actually very similar to how this group is run. So it's peer-led by somebody who lives with chronic pain. And each week there's different sort of topics, and we've developed this program with them. So I used to lead this group here at TAPMI, and then we've sort of trained people in the community to deliver the education. So a lot of people really like that. They like that, like being with like-minded people who understand what the experience with pain is, and they talk about different topics that we sort of mentioned throughout the presentation today. The Power Over Pain portal was created with us as well, but this is a Canada-wide resource. So all of the centers across the country that specialize in chronic pain, just like we provide here, came together to put all of the resources that we have sort of at our institutions together, so anybody can access. And they do monthly webinars too. So just like this, where it's over Zoom, you sign up, you can pick a topic that's interesting to you, and they offer them in English and French. I think they've paused the workshops or the webinars for the summer, but in September they have at least once a week a different topic, from like mood, managing your mood and pain, pain science, just like we talked about. Me and my colleagues do them quite frequently. Sometimes they talk about exercise, sexual health, different topics. So if you like sort of this more environment where you're getting to listen to other people, I just wanted to highlight those resources. But yeah, that's it for us. So if you're in Ontario and think you might benefit from some of the services that we offer, or would like maybe some eyes on some medications that you're taking, perhaps for pain, you can to be referred to our program. You can find the referral on our website, so tapmipain.ca. It just needs to be completed by a healthcare provider. So unfortunately, we can't self-refer to our program, but all of the resources that we just shared, you can sign yourself up. You don't need a referral from a provider. Yeah, thank you for inviting us.
Well, that's fantastic. Thank you so much. That's a lot of information, and it's really it's put some focus on how things work, and also how to make or to find some strategy or order to reduce pain as well. So thank you. Are there any questions right now? I guess we got nothing there at the moment. I was going to ask, when you talk about medications, are there different types of what are the perhaps different types of medication classes that they use for some of these things?
Yeah, so we have I'm trying to think off the top of my head. I don't want to give you the wrong answer. So we have different medications that work on different parts of the nervous system. So I think I mentioned like antidepressants. So those work by increasing those calming signals in our body. We also have medications that work on specific nerves. So sometimes it's local sort of creams and things that are sort of focused on those specific nerves in that one part of our body that might be causing pain. We have things like opioids, which we tend not to use in chronic pain, but they're sometimes used if like, okay, taking a low dose of an opioid is going to be able to control your pain to a point where you're able to engage in activity and sort of be able to do your activities of daily living. Sometimes there is a case for that. So yeah, it's hard to say because depending on sort of the diagnosis and gender too plays a part in some of the medications that we use. But a lot of the medications, like Sapor mentioned, like come with a lot of side effects. So some people are like, you know what, if it's only going to reduce my pain by 30%, I'd rather be awake and be able to like not have my memory impaired and like be able to manage on my own. But for some people, they're really beneficial and they're able to sort of over time get used to some of the side effects or come up with a strategy to manage them, so that they're sort of that helpful part of your toolkit when it comes to managing pain. There's specific modules on different medications, like on our TAPMI website, the Pain U online. And I believe there's also like different videos and resources on the Power Over Pain portal too, that will do a lot better of explaining it than I can. Yeah.
Yes,
Susan.
And you need to unmute yourself.
Okay. I was glad to see, Cara, that also that they are open to alternative medicine and and um, um, and moving away from heavy drugs per se. Um, you know, oh, pain creams, acupuncture, exercise. Yeah, there's a lot of different different ways to help, if you've got chronic pain and that.
Yeah, absolutely. So a lot of like what I do and my colleagues do collaboratively as like an interdisciplinary program is that we work on all of the different strategies that work on creating those paths in the woods, right? So we have that well-worn path where it's like very sometimes not helpful to us, right? When it comes to pain, like we're not managing well, that well-worn path is happening. So we want to create that better path where we're reducing pain, increasing function. Things like acupuncture, we actually don't provide at our center. Like some people find them very, very helpful, but it doesn't change those pathways. So some people, like there's still benefit. You can access them sort of elsewhere in the community because some people find them helpful. If like I'm in a really bad flare and it's in one specific spot, acupuncture 100% has a purpose, but it's usually sort of short-term benefit. So we don't provide those sort of in my program because it doesn't work. The evidence shows it doesn't change those pathways in the long term, which is what we want.
Yeah. I'm very fortunate because my family doctor, he believes in both. What you need prescription wise, and then alternative medicine too. He's done, on me. So it's it's wonderful that he is so open to that. Both yeah, getting his information from both sides, and trying his best to to help a person that is in pain.
Yeah, that's great.
Yes.
Yeah.
Okay. Was there anybody have any other questions or comments, or otherwise we'll let Karen Sephora go.
Okay.
Well, thank you so much, Karen Sephora. Wait, it's been a great presentation, and we'll look forward now to our discussion, and yeah, it's been good.
Thank you for inviting us. So Crystal has my email. If anybody thinks of questions after the fact, I'm happy to connect via email.
Good.
One
Hi,
question.
everybody. Yeah.
If I can just where does cannabis come into play here, or does it even?
Yeah, so one of our partner sites actually is doing a lot of research in cannabis and pain, and so I'm not entirely sure the specifics around like what parts of the nervous system it works in, but it works a lot on the synapse. So a lot of people find like, okay, when I smoke or whether it's edibles or prescribed sort of Nabalone, which is like a pill, it helps calm, right? So it's increasing those calming signals, but we don't have enough evidence to be like, this is exactly the part of the brain that it's working on. That's what we're working to do, because it's only been legal for so long. So from like an ethics perspective, we haven't been able to really do a big enough study on people with pain and cannabis because it's only been legal since like 2020. So right now, we're not exactly sure how it works on the nervous system, but the thought is that it's a lot around like that synapse and sort of those pathways through our nervous system.
Thank you.
Yeah, no problem. All right, it was nice to meet you all.
Thank
enjoy
you so
the rest
much.
of your day.
Okay.
Thank you
so much.
It was great presentation.
Bye,
Thank
guys.
you.